Good afternoon, everyone. This is Valerie Cape at CMQCC. We welcome you to the webinar today on intermittent fetal monitoring. We have muted everyone on entry, and we will be taking questions in the chat box. So as the presentation goes forward, we welcome you to type your questions in the chat box, and we will address them at the end of the presentation. I'd like to introduce our speaker today, who will be presenting. Her name is Holly Smith. She has been the co-lead and editor on the toolkit to support vaginal birth and reduce primary cesareans. She's also a consultant for the CMQCC statewide collaborative to reduce primary C-sections, and she's working with hospitals in Southern California. With that brief introduction, we'd like to turn the time over to Holly to share her presentation today and to share her expertise with us. Thank you, Holly, for being with us today.
Thanks so much for the introduction, Valerie. So welcome, everybody. Thank you for being on the call. I'm going to start out by apologizing for having this webinar rescheduled twice. Both of those were completely my fault, not that of CMQCC for sure. The first reason was because I had a baby, and then the second time it was rescheduled was because of a child care conflict that we just couldn't do it on that day. So my biggest apologies for that, but thank you for making it to the call today. We've had a lot of interest in this topic, and so hopefully today what I'll be able to give you are some tools in order to learn more about intermittent monitoring and further your knowledge. And by tools, I mean practical knowledge, but also real printable paper tools, readily usable things that you can take back today to your departments to begin to strategize about how to begin a program for intermittent monitoring. I also want to give credit where credit is due. I have a few slides in here taken from some other sources. One slide source was from a great presentation by the American College of Nurse Midwives annual meeting by Kathy Amice, a midwife, and her colleagues, as well as some information from Denver Health, who has published a lot of their quality improvement information, specifically about intermittent auscultation online. And so for those slides, I've noted where they occur. I just wanted to give the appropriate credit. So with that, we'll move into the objectives for today. We will review the goal of fetal monitoring and give some historical context. We'll also delve into understanding why the toolkit to support vaginal birth and reduce primary cesareans names intermittent fetal monitoring as a key cesarean reduction strategy. We'll review the benefits and the evidence in favor of intermittent monitoring, as well as the expert opinion regarding intermittent auscultation and, by extension, intermittent electronic fetal monitoring. And we'll review some of what's in the toolkit regarding the strategies for successfully implementing intermittent monitoring on your unit. And we'll also learn a bit about the basic methods of intermittent EFM and intermittent auscultation. First, I just want to note the acronyms in the presentation. If you read any of the Canadian or UK or Australian literature and compare it to ours, you'll see that the acronyms are often quite different. So just so that we're all on the same page, CEFM is for continuous electronic fetal monitoring, IA refers to intermittent auscultation, and IFM means just sort of an umbrella term for intermittent fetal monitoring, and that can be either by auscultation or by intermittent electronic fetal monitoring. So hopefully that makes sense to you all. Okay, if you've read the toolkit or been into the toolkit at all, you'll see that it is split into 4 sections, and they include readiness, recognition and prevention, response, and reporting. And in fact, in all of those chapters, we have a total of about 23 strategies to reduce cesarean, and all of those 23 strategies have sub-strategies. So the easiest thing to do is go to page 10 of the toolkit and take a look at the executive summary that summarizes everything really well. But for today, we'll be in part 2, which is the recognition and prevention section, which talks about supporting intended vaginal birth, with really a focus on redesigning maternity care for low-risk women. In that section of the toolkit, we outline 6 barriers to supporting intended vaginal birth. And one of those barriers is the overuse of continuous fetal monitoring in low-risk women. And in fact, electronic fetal monitoring is the most common OB intervention. After outlining the barriers, the toolkit outlines the key strategies for supporting intended vaginal birth. And I won't get into all of them right now. You can go to page 42 of the toolkit and see all the strategies for supporting intended vaginal birth. But I'll talk about 2 that are germane to today's discussion, which include implementing institutional policies that safely reduce routine intervention in low-risk patients. And in fact, ACOG just released a committee opinion last week or the week before about limiting interventions in labor for low-risk women. And then the second thing there, the second strategy, implementing intermittent fetal monitoring for low-risk women as a strategy for supporting vaginal birth. You can imagine that when we were writing the toolkit, especially with so many writers and advisors, we had a ton of different strategies we could have put in the toolkit to reduce cesarean. But our goal was to make it readable, doable, easily implementable, if that's a word, on your unit. So we had to really pare it down into the strategies that were most important. And so why did intermittent monitoring make the final cut? Well, here's why. For number one, it is evidence-based. Intermittent auscultation is associated with lower rates of cesarean and also lower rates of operative vaginal delivery. And the second reason is because there are other benefits to intermittent monitoring, which include increased mobility for the mother. If she can ambulate, she can use alternative birth positions, she can be in and out of the shower. And so any way that we can promote better comfort for her, we will engage that parasympathetic response instead of that fear response and hopefully reduce dysfunctional labor. So that's one benefit. And then the other benefit being that it focuses on high touch rather than high tech, which pretty much improves labor support, you know, when the nurse has to be in the room more often, auscultating the woman. Hopefully, theoretically, it should improve labor support. And we know that continuous labor support is also associated with a lower rate of cesarean. So a little background, and I know I don't have to say this, but just so we're all on the same page, the goal of fetal monitoring is, of course, to assess fetal well-being with the intention of diagnosing fetal intolerance in a timely manner before fetal asphyxia or other asphyxial injury occurs, like CP, stillbirth, or neonatal death. That's our goal. A little bit more background. Electronic fetal monitoring was developed in the 1950s by, I believe, Edward Hahn from Yale, Dr. Edward Hahn, and it was introduced widely by the 1960s, and it was thought to be far superior to intermittent auscultation. And I personally find this really fascinating, especially since today every practice is so based upon evidence-based medicine, right? And I suspect that back in the 1950s and 60s, they were practicing kind of in that manner, but nonetheless, introducing electronic fetal monitoring is an outlier in obstetrics because it was kind of just blindly implemented or kind of blanket implemented under the assumption that more info would be better. And so we see that by the 1980s, 60% or more of all labors in the U.S. were using electronic fetal monitoring, 80% by the 1990s. These are just kind of rough numbers, and 90% by the 2000s, and we know where we're at today with that. Continuous electronic fetal monitoring has been called, quote, a cautionary tale of unintended consequences, getting back to that previous slide about how we just sort of blindly implemented it without having an idea of how it might affect women and babies. It's been called a failure that could have and should have been predicted and thus avoided. And it's also been said to be no better than tossing a coin in its ability to predict abnormal outcomes. In fact, ACOG states there is an unrealistic expectation that a non-reassuring fetal heart rate tape tracing is predictive of cerebral palsy. Out of 1,000 fetuses with a non-reassuring fetal heart rate pattern, only 1 or 2 will develop CP. And yet, we continue to use it as though it's safer and will make things better. I feel like the vast majority of us just sort of have more comfort with continuous monitoring despite knowing this information. So let's get into the evidence in favor of intermittent auscultation. There have been multiple randomized controlled trials since the adoption of continuous monitoring as the standard of care. And back in 2006, the first meta-analysis, the first Cochrane review was released, which included 11 RCTs and about 33,000 women. And then in 2013, this was updated to include 13 RCTs and about 37,000 women. And there were no changes to the conclusions. And the conclusions were that compared to intermittent auscultation, continuous monitoring showed no significant improvement in the overall perinatal death rate. There was no significant difference in the cerebral palsy rate. Continuous monitoring showed a significant increase in cesarean birth and showed a slight increase in instrumental delivery as well. And there was one positive thing that came from it, however, and that was continuous monitoring was associated with a 50% decrease in neonatal seizures. But still, in terms of long-term for babies, no change in perinatal death rate or CP rates. And then there were also some subgroup analysis of this that was done for high-risk and low-risk women, and it was consistent among both risk groups. I've included here, just for if you want to go back and look at this slide deck later, some of the major studies that were done and the conclusions of each. I won't get into them now, but they're here in case you want to see them later. There has been some criticism, however. I think just, I should probably bring up that there are some critics of this that say that most of these studies were not high-quality studies. Maybe 2 or 3 of them were actual high-quality studies. And that they were mostly conducted at a time when cesarean rates were low. And so do we have the numbers and to confidently reflect better outcomes? And the answer to that is that the experts believe that we do. In fact, the ACNM says that intermittent auscultation is the preferred method for low-risk women. ACOG says intermittent auscultation is acceptable for women without complications. And I like AWON's explanation the best, actually. Women's preferences and clinical presentation should guide the selection of monitoring method, with the least invasive method being the preferred one. Okay, so I'm just going to back up a little bit because I think there might be a little bit of confusion when I talk about intermittent fetal monitoring versus intermittent auscultation. I've just presented to you all the evidence about intermittent auscultation. So why then does the toolkit refer to sort of this blanket statement, this umbrella statement of intermittent fetal monitoring? Especially since as far as I know, there are no studies that compare intermittent auscultation to intermittent electronic fetal monitoring. And in the few studies that compare intermittent EFM to continuous EFM, there seems to be no difference in outcomes. And also, intermittent auscultation is the prescribed standard of care for most low-risk women in the UK and Canada, for example. So as far as we know, if you were to choose between the two, intermittent auscultation seems to be superior to intermittent EFM. But we combined them in the toolkit for a few reasons. The first thing is that we wanted facilities to have a choice of what works best for their environment. So if you are from a place that is seeming to be particularly resistant to having an intermittent monitoring protocol, don't discard the concept of intermittent monitoring simply because you can't or are unwilling to introduce intermittent auscultation. Maybe you should consider intermittent EFM instead, or to start out. The second reason we did this is that intermittent fetal monitoring, either by auscultation or by intermittent EFM, is the gateway to freedom of mobility in labor. And I talked about this in a previous slide, but mobility means more choices for coping, position changes, walking, using the shower and so forth, and improved coping means less dysfunctional labor. So really that point really can't be overstated, so important. The third reason we did this is that successful introduction of intermittent fetal monitoring, either by auscultation or intermittent EFM, hopefully will begin to change your unit culture towards one that embraces normal birth and makes everyone begin to question or be curious about reducing other routine interventions. To me, I think it's actually kind of a tipping point intervention in the sense that it may move the culture of your department towards one that values normal birth. And by normal birth, I don't necessarily mean an unmedicated birth or a non-epidural or midwife birth, that kind of thing. What I mean is just this concept of protecting the normal physiologic processes that will hopefully lead to a vaginal birth. And the first way to do this is to reduce interventions that aren't needed. And finally, the last reason we did this is that intermittent fetal monitoring, either by intermittent auscultation or intermittent EFM, requires or fosters more bedside labor support than continuous fetal monitoring. And I brought this up in a previous slide. And continuous labor support is also known to significantly improve the chances of spontaneous vaginal birth. So that's why we created this umbrella term that encompasses both intermittent auscultation and intermittent electronic fetal monitoring. So in the toolkit, we also provide some guidance on the major components necessary to implement a successful program in your department. And there are 5 of them. They include providing patient education and engaging in shared decision-making. Number 2, implementing initial and ongoing training for nurses and providers. Identifying the appropriate patients. This is probably one of the most important. So policy should include exclusion criteria. Ensuring appropriate nurse staffing to accommodate safe intermittent fetal monitoring, and making intermittent fetal monitoring the norm on the unit, at least for those women that don't meet the exclusion criteria, so for the normal low-risk woman. So let's get into each of these briefly. So the first, providing patient education and engaging in shared decision-making. The toolkit actually outlines 5 patient decision points that women should know about that impact their risk of cesarean. And you can read them all here. But one of those patient decision points that should be brought up prenatally, not only while she's in labor, but prenatally, the provider and the woman should talk about the choice of fetal monitoring, and that the fact that continuous monitoring is associated with an increased risk of cesarean. And then on the right side there, you can see that we include the SHARE model. This is from the HRQ website that has an entire toolkit devoted to how to do shared decision-making and how to train folks on your unit in shared decision-making. And essentially, what needs to happen is that there needs to be a prenatal conversation about continuous versus intermittent monitoring, and then another conversation in labor, probably one that's a little bit more brief, that goes over the risks and benefits of each, takes her birth plan into consideration. For example, what kind of support does she want? What kind of coping plan is she going to have? Is it going to be an epidural or not? Combining that with her risk status as well as her physical assessment, and hopefully together you can come up with the best method of monitoring each woman. And here we have just, so you know, in Appendix D of the toolkit, the tools are arranged by topic. And you can go to fetal surveillance, and you'll find a few downloadable patient decision aids that can help you explain continuous versus intermittent monitoring to the woman, as well as help her make a decision. And these are all freely usable, just out there on the internet. We've vetted the information, and you can incorporate that into your practice. Okay, so the second thing to help make a successful program for intermittent monitoring is to implement initial and ongoing training. which it seems obvious, but how are you going to do this? Where are you going to get your information from? So one of the first places is if you are thinking about implementing intermittent auscultation, I would direct you to the ACNM, the American College of Nurse Midwives Birth Tools website, and to use the intermittent auscultation bundle as your roadmap. The ACNM is actually doing their own national program for reduction of primary cesareans through the implementation of 3 bundles that focus on physiologic birth, and one of them happens to be this intermittent auscultation bundle, which is really well laid out and will be a really good guide to what needs to be functioning on your unit for this program to be successful. You can download this at the website that I've noted there, and you can also find it on page 89 of our toolkit, but I definitely recommend going to the Birth Tools website because in addition to the bundle, they also provide algorithms, some audit tools, model policies, and so forth. So lots of stuff that can help you get an intermittent auscultation program up and running. Additionally, the A1 guide, here's the website here for ordering the fetal heart rate auscultation book. I highly recommend that to sort of guide your training for nurses. Also, the American College of Nurse Midwives, their clinical bulletin is located there. You can see at the bottom the journal number. Is a really good how-to guide for intermittent auscultation, just sort of walks you right through it. So these are just a few tools that you can use to get your training program up and running. I've also included here, this is actually, we got permission from Riverside University Health System. This is their competency assessment and validation form for RN training. And I know it's probably hard to see here, but I included it because if you email me after the presentation, if you want just the slides so that you can zoom in and see this a little bit better, I can certainly send you my slides so that you can have a template to go from. And additionally, we will be putting a lot of this intermittent auscultation, intermittent monitoring stuff up on the CMQCC website under resources. So in a couple of weeks, that will be available to you. But in the meantime, if you want to see it up more closely, just send me an email. My contact information will be at the end of the presentation, and I'm happy to send this to you so that you can review it a little more closely. Okay, here's a really important thing, is identifying appropriate patients, because obviously intermittent monitoring is not for everybody. So policies need to include exclusion criteria. So the first thing to remember is that intermittent fetal monitoring is for low-risk women. And honestly, there's no great definition of what is low risk. ACOG and A1 and ACNM haven't agreed on a definition of low risk. But for our purposes here, low risk is going to refer to women who are term, and I'll say at least 36 weeks instead of 37, so at least 36 weeks with a singleton fetus in vertex presentation with a Category 1 tracing on admission, or alternatively, no persistent or severe decelerations on admission. So protocols kind of vary with this. I've seen many, and some will say that you need a Category 1 tracing, and others will say simply no persistent or severe deceleration. So just keep that in mind, but accelerations are not required. Okay, so if you meet all of those, then you can proceed. Exclusions to intermittent fetal monitoring. I see a question here. Term pregnancy is 37 weeks, and you're completely right, and that's why I added the parentheses 36 weeks, just because that seems to be the general consensus in the many protocols that I've seen, just that 36 weeks tends to be the general consensus for when it's appropriate. Sorry, that's confusing. Okay, so exclusions to intermittent fetal monitoring are generally the same and getting questions, please send us the slides. Okay, certainly will.
Holly, this is Valerie, and I have posted this a couple times. The slides will be available on the CMQCC website, and I think that would be easier to download than having Holly send them all directly to everyone who asks. So they will be on the CMQCC website available.
Yeah, I was only bringing that up in case it's really small and they can't zoom in because it won't be an actual PowerPoint slide, so that they could see that audit tool a little bit more closely.
I will keep track of who's asking for them, and we'll get them to you.
Very good. Okay. The exclusions to intermittent fetal monitoring are generally the same in most hospital policies with a few differences, and I will get to those differences in one of the next slides. But the key point being that your exclusion should focus on the conditions associated with uteroplacental insufficiency and or conditions associated with a cord blood pH of less than 7.1 at birth, just to help you narrow down what the exclusions should be. So I'm going to show you a few different examples here. My screen is kind of small, so I'm hoping that you all can see what you should be seeing. This first example is from the Society of Obstetricians and Gynecologists of Canada, and this is a really useful resource. And in fact, if you were to just plug in the name of this here, the Antepartum and Interpartum Consensus Guideline from them, it's readily available online and free for download. And this shows their exclusion criteria. So you can see here hypertensive disorders of pregnancy, pre-existing diabetes, maternal medical disease, fetal stuff like IUGR and oligo. So, you know, all this, the basic stuff we would expect would be in exclusion criteria for intermittent monitoring. Here's another example, however. This is from Zuckerberg San Francisco General Hospital, and they allowed us to use their policy, and it's located on Appendix T in our toolkit, page 121 of the toolkit. And you'll see they added a few more interesting things like drug use during pregnancy, even lupus and thyroid disease. Moving down, we see a history of IUFD as an exclusion criteria. Under labor, they've added epidural anesthesia. So you can see there's some variation here. The next slide is from Denver Health, their exclusion criteria. Pretty much the same, but they've added also cigarette smoking, TB and other infections like HIV. You'll notice that oligohydramnios is actually not on their exclusion criteria, I don't think. So there is some variation between the policies, but the main exclusions are the same. So here's some of the disagreements that you'll see between them. One is misoprostol. Does that require continuous monitoring? The majority of the protocols I've seen state that there should be continuous monitoring for the first 1 to 2 hours after dosing, and then you, if everything looks normal, can go to intermittent monitoring protocol. Oligohydramnios. You know, some of these things may require your department to compromise on certain things despite the lack of evidence. But in many of protocols I've seen, if things are really normal, meaning, so for example, a post-term pregnancy that has no other fetal or maternal issues and just sort of has this post-term oligo, may be able to do intermittent fetal monitoring after they have a contraction stress test. Epidural, I think across the board in America, or at least in California, what I've looked at in California, epidural requires continuous fetal monitoring. But if you look at the Canadian guidelines, you'll see that that's not included, and they do make a point in their guidelines that in some places in Canada, epidural is not actually an absolute contraindication to intermittent fetal monitoring. Meconium, some places will say only thick meconium requires continuous monitoring, but not thin meconium. Narcotics, we see differing viewpoints on that. Prolonged rupture of membranes without chorio. So if we went back and looked at that other slide, the Canadian guidelines say greater than 24 hours of rupture needs to be continuously monitored. While many protocols I've seen recently say as long as there's no chorea or fever, prolonged rupture of membranes in and of itself is not a reason to continuously monitor. So just to give you guys an idea of some of the conversations taking place around these things. Okay, one of the other things for a successful program is to ensure appropriate nurse staffing. So obviously this is critical to the safety and success of the program. This could be an implementation barrier, or at least a perceived barrier, especially for those high census facilities. AWHONN recommends 1-to-1 for intermittent auscultation. I have seen that many facilities wait until the second stage to initiate 1-to-1, and then also, of course, as needed based on if there are changes in complexity of the patient or the need for increased frequency of assessment. So nurse staffing is a hard one because there will be times where intermittent monitoring or intermittent auscultation for sure may not be safe if things are just crazy on the unit. So sometimes that becomes an exclusion. If it's happening all the time, then you may want to question whether or not this is really something that's actually happening, or if it's just that folks don't want to do intermittent auscultation. But sometimes there's a real reason regarding staffing to not do it. All right, and the final thing for a successful program is to make intermittent fetal monitoring the norm for women who do not meet the exclusion criteria. So one of the things we talk about in the toolkit is that in many places right now, continuous fetal monitoring is the norm and is in the orders, and the only way to do intermittent fetal monitoring is to have the provider rewrite those orders. We hope that that changes. Nurses are smart enough and skilled enough, if they have the exclusion criteria in front of them, can make really good skilled decisions about who should have intermittent fetal monitoring. And if the provider wants a patient to have continuous monitoring, then there should be an order for that. So that's what we're hoping that facilities can move toward. But also to make intermittent fetal monitoring the norm, it's really going to take a substantial QI program. And so all of these things I've listed here are necessary for the success of any quality improvement program, but definitely germane to this one as well. So the first thing you'll want to do is assess your readiness for implementing this type of thing on your unit. And you can go back to the ACNM bundle that was on the previous slide from the American College of Nurse Midwives. Their IA bundle is a really good resource for this. This will help you map out where you're at right now and what you need to do. Provide a review of the current evidence, what we've talked about today, to all stakeholders, because staff buy-in really is critical. This will require support from everybody because, think about it. What are you going to do when this is the protocol, but then you get pushback from physicians who say, I need to see a strip. I'm not going to make any decisions till I see a strip for you, instead of taking the nurse's word that the fetus is healthy. So from there, getting policies and training underway. Obviously, only trained staff should participate. I say that because there is a difference between intermittent electronic fetal monitoring, which is fairly easy to implement, and all nurses are trained on that already. Intermittent auscultation takes a little bit more training, and so we shouldn't just lump them together and say, here's your policy, get going on it. That's not going to work, and that's going to be the quickest way to having a failed program. Consider implementing in stages. So maybe you really do want to work towards intermittent auscultation, but you know that there's resistance on your unit. So maybe start by implementing intermittent EFM. See how that goes. See how it's received, and then begin implementing intermittent auscultation. And then if that goes really well, some places have even considered replacing the routine admission strip with intermittent auscultation for low-risk women. But you kind of want to do it in stages. The other thing that's important is to advocate for use on all low-risk women. So if this is in your policy and procedures, this is not something that you can say, okay, this is really just for like the midwife patients or those nurses who are really good at labor support, because then you're not going to get that critical buy-in from all the staff. To change the culture on your unit, this really needs to be the norm for low-risk women, regardless of who the provider or the nurse is. As with all quality improvement projects, small tests of change go a long way. So, perhaps you'll want to train a couple of nurses, and then they will roll it out with their patients for a couple of weeks. And you kind of see how that goes, collect and analyze and look at your data, and then maybe have those same 2 nurses and a couple more do it over the next period of time and analyze it again and see how it goes and what you should tweak and what you should change. You're definitely going to want to celebrate those successes. And remember that change does take time. This is a big culture change. So along with that is going to go the culture shock, right? So just remember, Rome wasn't built in a day. It will take some time. And by the way, I see a lot of questions coming up on my screen. So at the end, I will go through these. All right, so now we're going to do kind of a short crash course in intermittent fetal monitoring. I hate saying crash when we're talking about cesarean and monitoring, but nonetheless, we'll do a short course here. Obviously, there's a few ways to intermittently monitor. One is by fetoscope for auscultation, another is by Doppler for auscultation, and then the electronic fetal monitoring for intermittent EFM. Let's start with intermittent EFM because that's kind of the low-hanging fruit. This is fairly easy to implement because you already have the monitor in every room. Nurses are already trained to use the device. And you'll likely have better buy-in in institutions with a high intervention culture. But I also have a little note here to keep in mind that these kinds of units will benefit the most from intermittent auscultation. But certainly intermittent EFM is a choice. So let's do the where, when, and how. So the where of intermittent EFM is obviously at the bedside unless you have a telemetry unit available. And I like to bring up that potential barrier or challenge here is that you kind of have to interrupt the woman's current coping process. So sometimes that can be disruptive. So think about that when you're monitoring. The when. So there's pretty much consensus here now about the frequency of monitoring. In latent labor, A1 and the Society for Obstetricians and Gynecologists of Canada say every hour. I've seen variations in this on units where maybe the woman is very, very normal and she's been admitted in early labor. Perhaps you could just do the intermittent monitoring with vital signs. So maybe that would look like more like every 2 to 4 hours for some women. But A1 says every hour. In active labor, every 15 to 30 minutes. And in the second stage, every 5 to 15 minutes. So maybe if she's laboring down, for example, you might do it every 15 minutes and then with active pushing every 5 minutes. Or if anything's changing in the fetal heart rate and you just want to take a better look, you would change to every 5 minutes regardless. Then, of course, before and after vaginal exams, rupture of membranes, administration of narcotics, ambulation, and then after any significant event that might arise, like if you see some abnormal bleeding or a prolonged contraction and so forth, as just a couple examples. And the how, so here's the preparation portion. This should not be rocket science to anybody. This is a basic way to do continuous monitoring as well. So the first thing, obtain a reassuring 20-minute continuous tracing on admission or during observation. Remember that accelerations aren't necessary. And then your unit has to decide whether you'll require a Category 1 tracing or alternatively simply the absence of persistent variable or late decels. All right, and then obviously you're going to apply the fetal and toco transducers and simply obtain a 3 to 5 minute tracing ideally through a contraction. And at the very minimum, you should at least get a 2-minute tracing. That should include before, during, and 30 seconds to a minute after the contraction. There is a potential challenge here, and that is the temptation to leave the woman on the monitor. I think we've all, potentially done this before. Maybe things get busy, and then that 3 to 5 minutes is actually a half hour, an hour, or 2 hours. Or maybe she's sleeping, and you don't want to go in and bother her while she's resting. And that really kind of negates the purpose and the goal of intermittent fetal monitoring. So this is where that shared decision-making is critical, and you'll want to speak with women about, I'm going to be coming in while you're resting to do this. Or maybe she doesn't want that to happen, in which case you kind of tweak the plan as you go. So just bear that in mind, that there is a lot of temptation to kind of leave the woman on the monitor and slowly turn into a continuous monitoring process. Documentation is the same as it would be for continuous monitoring. Your baseline, fetal heart rate variability, presence or absence of accelerations, and of episodic or periodic decelerations, any changes or trends you might see in the fetal heart rate. For uterine activity, the mode will likely be TOCO, but maybe you're running around the unit chasing this woman who's ambulating, and maybe it's just through palpation that you're looking at uterine activity. Looks like one of the bullets are gone there. That should be frequency, duration, and intensity of the contraction. Sorry, that's missing there. I'm not sure why that is. All right, so that was brief intermittent electronic fetal monitoring. Now let's look at intermittent auscultation. So first I'll bring up a few challenges with auscultation that you need to think about. The first is that it requires Dopplers in every room. And maybe, maybe that's extreme. Maybe it doesn't require Dopplers in every room, but you certainly need enough to be able to provide auscultation for every woman that wants it. So that's the key point. You don't want to be, you don't want to have 2 Dopplers and then you have many women on the unit that want it that day and they can't simply because Dopplers aren't available or hard to come by. It obviously, like I said before, requires enhanced training beyond intermittent EFM. One of the criticisms is that you cannot assess variability with intermittent auscultation. Also, the type of deceleration is difficult to determine since you're not seeing it on a strip. You're palpating the contraction, so you don't exactly know, is that an early decel or late, and so forth. Like I said before, A1 recommends 1-to-1 staffing, which can be a challenge, and the permanent record consists only of the nurse's notes. So I have seen compromises to this, however, in some policies require a 20-minute EFM tracing every 2 hours. So this is kind of intermittent auscultation with kind of augmented episodic EFM. I don't know how I feel that. It's certainly not necessary to do that, but it might be one of those compromises that is necessary on your unit in order to introduce this plan. All right, the where, when, and how. So for intermittent auscultation, the where, the possibilities are endless. She can be in the bed or maybe in the shower, the tub, on the ball, walking, standing, squatting, on the toilet. So that's the great thing about intermittent auscultation is you can go where the woman goes. The when, so this is exactly the same slide as the intermittent EFM. So every 1 hour or maybe 2 to 4 hours, depending on latent labor, 15 to 30 in active labor, 5 to 15 in the second stage. And before and after vaginal exams, rupture in membranes, and so forth, and after any significant event. All right, so let's go into how to do this. This is always where the big questions come up. The first, of course, just like before with EFM, obtain a reassuring 20-minute continuous tracing. Accelerations aren't necessary. You'll also want with you a visible watch, a clock, or a smartphone these days that everybody carries with them that can show seconds. important to remember that this is going to take some concentrated listening, and as you're getting used to doing this, it might take some time. So you want to assist the woman into a comfortable position for listening so that she's not in some crazy, difficult, painful position while you're doing this. Continuing with preparation here. And then you'll want to assess her contractions, so assess frequency, strength, and duration through palpation and also through asking her. Definitely want to determine her pulse rate, whether that be by just taking her pulse on her wrist or using the pulse ox, so that you can differentiate between maternal pulse and what you're auscultating. And then just like you would do with EFM, you're going to perform Leopold's in order to find the fetal back and put the auscultation device in the right place. Okay, so here's the how of the procedure. First, obtain a baseline. So you're going to auscultate. The easiest way to do this is to auscultate between contractions for about 60 seconds and just get the exact rate for that 60 seconds, and then do it again after the contraction to sort of verify your baseline. Okay, so now you have your baseline, and then you're going to determine the response to the contraction. And you'll do this by beginning to auscultate at the peak of the contraction, and then you're going to continue for about 30 to 60 seconds after the end of the contraction. So you can already tell that doing intermittent auscultation takes extremely focused listening and counting, because you're kind of, you're looking at the clock, you're counting, you're documenting a little bit, or doing a little chicken scratch as you're counting, and you're palpating all at the same time, okay? Anyways, getting back to that, in order to determine the response to the contraction, you're going to use what's called a multiple count strategy, where you're going to do 3 10-second counts separated by 5-second breaks, okay? So basically for 10 seconds you listen, jot down that number, wait for 5 seconds, do another 10-second count, jot down that number, wait again, and then do that the third time, okay? Then on your little scratch paper there, you have your numbers. You multiply each of those by 6 to get the fetal heart rate. And this method actually has a 90% accuracy for identifying late decelerations. And it identifies actually accelerations really well also. And I'm sure there's going to be questions about this, but I'll move on in the slide deck, but I can talk about that a little bit more at the end. And you'll be noting fetal movement at the same time, and then you'll be documenting. But before you can document, you need to know how to interpret what you have. So it's actually pretty consistent with the NICHD guidelines for Category 1 and Category 2. So Category 1 would be a normal fetal heart rate baseline between 110 and 160 with a regular rhythm, presence of fetal heart rate increases, but absence of decelerations. Category 2 would be anything that had just sounded to you to have an irregular rhythm, has any decelerations, obviously any tachycardia above 160 for greater than 10 minutes, or any bradycardia less than 110 for greater than 10 minutes. And you cannot determine a Category 3 through auscultation because you can't assess variability, so keep that in mind. All right then, so then the documentation would include maternal heart rate for the fetus, whether you used a Doppler versus a fetoscope, the baseline, whether the rhythm was regular or irregular, the presence or absence of increases, presence and decreases. Once again, note that the type of deceleration is difficult to assess and you can't assess variability. Mode, which would usually be palpation, right? Frequency, duration, and intensity of contractions. So that's what you'll want to have in your documentation. Here's a sample documentation. This is actually a really great resource that we will put up on the CMQCC resources site. This was just published end of last year, 2016, from the the Journal of Australian College of Midwives, titled "Putting Intelligent Structured Intermittent Auscultation into Practice," and it's a great resource. I highly recommend it. Here's a sample documentation There's a lot of stuff on the top there that may or may not be necessary to put in every note, but you can see here what the necessary part of the note. The uterine activity, contractions are coming every 3 minutes and lasting 50 seconds. The palpate is strong and the uterus is soft between contractions. The fetal heart rate, average fetal heart rate, or what we would say is baseline, 130 beats per minute, determined over 10 minutes. The fetal heart rate counted during the fetal movement is 148, and there were no decreases when counted after the end of the contraction for 1 minute, and the rhythm is regular. You can see all the important stuff included there. So then what do you do if fetal heart tones are non-reassuring? Just like you would do if the woman was being continuously monitored, you would administer the same resuscitative measures. So you may increase the frequency of assessment, you're going to change her position, give a fluid bolus, put on some oxygen, notify your provider. And depending on the severity, you may need to change to electronic fetal monitoring if you're using auscultation until you're reassured. Again, this is a really good resource from the Society of Obstetricians and Gynecologists of Canada that we'll also put on our website. And I include this because what it shows here is that you don't necessarily always have to revert to the electronic fetal monitor right away. It kind of just depends on the severity of what's happening. Obviously, if you have a significant bradycardia or this deep decel, sure, you're going to go ahead and you're just going to put on that monitor really quickly. But outside of those things happening, you would auscultate the fetal heart rate. If it sounded abnormal, you would auscultate again. Perhaps then you would do your resuscitative measures and then auscultate again. And then if it's still abnormal, you'd go ahead and put on the electronic fetal monitor. So I just want to bring that up to show that you don't necessarily have to jump to that right away. It's just sort of dependent on the severity of what's happening at the time. So that brings us nicely into, when do you change to continuous electronic fetal monitoring? Well, you could go back and look at the slides to see the criteria that each of those 3 places, Denver Health and San Francisco General, used as exclusion criteria during labor. But just to review, they include an abnormal fetal heart rate with persistent decelerations, abnormal rhythm, or bradycardia, for example, or tachysystole, abnormal bleeding, thick meconium, chorea, a woman switches over to epidural anesthesia or becomes suddenly hypertensive, or maybe you need to augment, so you need to start Pitocin, or maybe she was being induced with misoprostol. Also, I already brought up staffing issues, or perhaps you just can't distinguish between maternal and fetal heart rate. So these would be indicators to switch over to continuous. So here's another resource that you could that we'll put up on our website. It's actually the same one that the one from the Journal of the Australian College of Midwives that shows a wonderful algorithm of how to assess risk during labor, and then what would make you want to change to continuous monitoring, and then also if things return to normal. So perhaps you have a 20-minute strip of a Category 1 tracing, you could then go back to intermittent auscultation or intermittent monitoring. So this is another great tool to just walk you step by step for what to do when. All right, I actually can't believe we're at the end already. So if you have more information about, that you want more information about this, you can contact me at that email there, or if you just have questions about the toolkit, for example. You can also download the toolkit at the CMQCC website. Valerie Cape is on the line right now, and you can email her if you have more questions about our collaborative to support vaginal birth or just any other questions about CMQCC in general. And now I'm going to kind of go through some of our questions here that have popped up on the screen.
Holly, do you want me to read them out to you?
Sure.
Okay. So there was a question, if the Doppler has an electronic rate built into it, that could help obviate the need for all the 10-second counting, perhaps?
That's actually a really good question. And this actually comes up all the time, the Doppler is kind of the same as the continuous electronic fetal monitor, in that the rate that you're getting on your screen is not the actual rate at that moment, which sounds funny, right? But it's actually a reflection. The computer technology is reflecting back to you. It's kind of taking the beat that came before it and the interval between the current beat and reflecting back to you what the beat per minute would be if it continued for an entire minute. But obviously we know that the heart rate changes, right? So that's called variability, and it changes from beat to beat. So in fact, it is more accurate to do the actual count, and that's part of the accuracy of intermittent auscultation, is doing the actual count over an extended amount of time, like 1 minute, and listening for those variations or increases and decreases. But you can use it as kind of a confirmatory tool. So midwives and nurses who have gotten really good at this are kind of, they're palpating the abdomen, they're watching their clock, they're having a sense for whether they're hearing increases or decreases, and they also kind of look down at that monitor and see that number being read out to them. And then they can go back and use that kind of as a confirmation for what they get in their count. I hope that makes sense. Other questions?
Okay, so the next question is, for legal purposes, do you recommend that we turn off the monitor paper when using the fetal monitor to obtain the fetal heart rate so that there isn't a paper trail?
That's interesting. So I see that Lisa Miller recently told this to staff. Yeah, maybe. I think that really just kind of, I would defer to Lisa Miller. If she's saying that, I would go with it. But it would really just depend on the policy of your practice. Because sometimes there will not be buy-in to this kind of program unless the physician or the provider can see a printout at a certain time. They for whatever reason, want to have that, I guess they just feel better about seeing something in front of them. So it really will depend on what your department decides to do.
And there's a question about, is there a national standard procedure for IEFM similar to the standard for IA being developed?
Not that I know of, but I will look into it. That was from Mary.
Okay. Yeah, Mary Campbell Bliss. And then there's also, go ahead. There's also a question about the AWAN course, and it's an intermediate monitoring course. Is that a good method or a course for interpretation of the process for IA?
Good question.
And the method education?
I have not taken the course, so I don't know. I'm familiar with the book, but I'm not with the actual course that they give.
Okay. Thank you, Holly, for that great presentation. We have just about 3 minutes left before the top of the hour. If anyone else wants to get in a quick question, you can type it in the Q&A box at this time. We really appreciate the time that Holly has taken to do this webinar for us. As I said at the beginning of the meeting, the slides from today's presentation and a link to the recording, if you would want to view the meeting again, will be posted on the CMQCC website in the next couple days. And so we recommend that if you'd like to, you can download those and you can view the meeting again if you wish. And for the download of the toolkit, if you haven't already downloaded it, it will require a site registration and a short survey before you'll be able to download the toolkit. So if you have any questions about that process, you can contact me, Valerie Cape at CMQCC, or sorry, vcape@stanford.edu. It looks like there's another question. Go ahead, Holly.
So we have many women that present without prenatal care. Is this considered a risk factor and would exclude them from IFM? No, it would not necessarily exclude them, but I do see it in some of the exclusion criteria for some policies, but not necessarily, because you could potentially. It really depends on some other things like what else is associated with their lack of prenatal care. For example, drug use. So when you kind of get multiple layers there, you may want to consider that they would be better off with continuous monitoring. But in and of itself, not necessarily. If you can have that initial tracing, that looks good. And if they continue to have auscultation or IFM, that sounds like things are doing well for the baby.
Are there hospitals that have remained with the 1:2 ratios during latent phase of IA?
Let me see where I can find that question.
It's up in the chat box, and I'm not sure if you can see that or not.
So repeat
it's not in the Q&A box.
Okay, go ahead, say that again.
Are there hospitals that have remained with 1:2 ratios during latent phase using IA?
Yeah, I mean, during latent phase is particularly when you probably wouldn't need 1-to-1 as much as you would during active phase. I think that's the question.
Okay. And the next question, how do providers who are focusing on IA able to maintain focus on the woman's experience and helping her with their coping?
Oh, is this a question going back to like how does it sort
for
of
the
improve?
Count.
How does it improve labor support? Is that the question?
Yeah, how can they focus on IA but able to continue their focus on the woman's experience and helping support her labor?
I see. Yes, so at the time of doing the auscultation, obviously they're going to be extremely focused on just doing that. And it may even require that you're telling people in the room to be quiet for a moment so that you can do that. But at least hypothetically, it requires that the nurse is in the room more often and checking on the patient more often, engaging with the patient more often, actually having more of that high touch. And so in that way is hopefully engaging in better labor support. Of course, that's theoretical, but that's what we hope would be happening.
Okay. And there was a question about, are you suggesting that variability is the standard of care for IA? It's my understanding that IA was safe and effective using baseline FHR listening before, during, and after a contraction. Variability is not required?
Right, that's exactly right. I hope that was not misunderstood. Variability is not required. You can't see it anyways with intermittent auscultation. So that is exactly right. The only thing that is required is that you get the baseline rate, that you're listening for any accelerations or decelerations. When we have variability, we know things are going well, right? But you don't necessarily have to know that for the simple fact that it often takes a period of time before things worsen, usually, right? This is not always the case, but usually there's a period of time before things get really bad. And you are going to be able to hear that and be picking up on these decelerations, whatever it may be that's occurring. And then from that information, you would probably switch over to electronic fetal monitoring, and then you would see whether or not the variability was there or not. So the questioner is exactly right. With auscultation, you can't hear variability. It's not required.
Okay, and then there's just a couple comments that I'll read out so everybody can see them just in case. They recently heard at Lisa Miller's EFM class that there might be a legal concern if there's only 3 to 5 minute segments of EFM strip on a compromised baby. And then the other comment is their understanding is that studies of IA used intermittent auscultation with handheld Doppler, not the transducer from EFM. So does that mean that the handheld Doppler is preferable to the EFM transducer?
Okay, so the first one, recently hearing at Lisa Miller's EFM class that there could be legal concern if you only have 3 to 5 minute segments of strip in a compromised baby. Yeah, most likely there would be. So that would be the case where you would potentially switch over to continuous monitoring, right? Okay, that other question, let me just read it real quick here. My understanding is that studies. Yes, so the question is whether, okay, the studies for intermittent auscultation were done with a handheld Doppler, not with EFM transducer. So does that mean that the handheld Doppler is preferable to the EFM transducer? Well, probably, because that's the best information we have but it's not required, and certainly the EFM transducer works in the same way that the Doppler does, and kind of just use what you have.
Okay.
But she's absolutely right. The information we have is based on the Doppler with auscultation.
Okay. Great. Thank you, Holly. That's all the questions that have come in for the presentation today. Thank you so much for your time, and thank you, everyone, for being on the call. And with that, have a great afternoon. Take care. Bye-bye.
Thank you.
Thanks, Holly.
Thanks. No problem. Hope
Bye.
everybody had a good time. Bye.